Welcome to this Genomics England seminar series. This seminar series is held to demonstrate the best research from Genomics England and our partners. These are monthly, free-to-attend talks presented by Research Network members on the latest research being performed using Genomics England data. My name is Giampiero Cavalieri. I'm a professor of human genetics at the Royal College of Surgeons in Dublin, Ireland, and also an investigator in the Future Neuro Centre. I co-lead the Predisposition and Screening community. This month, the research seminar will focus on the Generation Study, a landmark UK initiative run by Genomics England in partnership with the NHS. And this is exploring the feasibility, impact, and ethics of using whole genome sequencing in newborn screening. This seminar is recorded and will be available afterwards on the Genomics England YouTube channel. In terms of the format, today's seminar is 1 hour long. There'll be 3 talks followed by a Q&A session. If people have questions, you can submit them using the designated Q&A feature. And if you could use that rather than the general chat, please. Or if you wish, just wait until the Q&A section, raise your hand, and we'll unmute you so you can ask your question verbally. There are 8 different research network communities within Genomics England. The purpose of these communities is to foster collaboration with fellow researchers, to enable sharing of skills and expertise, and to share the latest developments and opportunities relevant to community members. Today's seminar is, of course, associated with the Predisposition and Screening community. The work of this community beyond screening looks at the role of de novo variants, of segregating variants in disease predisposition and also causality. And we're also looking at polygenic risk scores, combinations between common and rare variants, and AI tools to help with this effort. This slide is showing you the leadership of the Predisposition and Screening community. So we're a combination of PhD geneticists, as per myself, with clinician scientists in Sanjay Sisodia, who's a neurologist based at Queen Square in London, and Professor Elijah Baer, who's a consultant cardiologist based at St. George's in London. Our 3 talks today are focused on the Generation Study, and this aims to recruit 100,000 newborn babies and to screen them for over 200 genetic conditions. Recruitment began in 2024, and the study is currently scheduled to run until 2027. So the first talk by Dalia Kasperaviciute will provide an overview of the Generation Study, as well as some early results of the program from around 10,000 participants. And Dalia is going to provide some reflections on the learnings and challenges that have emerged from the first year of the study. The second talk will be by Joanna Ziff. She is going to look at present the evaluation framework for really building the evidence to provide that framework for evidence-based decision-making. So she's going to provide an overview of the approach used for developing the evidence base for newborn whole genome sequencing, as well as the approach to evaluation activities to build that evidence base for possible future commissioning. And our final talk today will be from Harriet Etheredge. She's an ethicist. She's going to explore what the lifetime genome might be with examples of use cases and the main risks to anticipate. As well as those risks, she's going to explore the benefits and potential uses of reanalyzing a person's genome periodically over their lifetime. Before I introduce our first speaker, a reminder these seminars are held monthly on the last Tuesday of each month from 2 to 3. They are online, they're open to everyone and free to attend. So Dalia, if you would like to begin sharing your slides, please, while I introduce you. So Dalia is Scientific Director for Genomics England. She joined Genomics England in 2017. She leads the development and oversight of the genome analysis pipeline for the Generation Study. She holds a PhD in human genetics from Vilnius University. She completed a postdoc in neurogenetics at University College London Institute of Neurology and Duke University. Before joining Genomics England, she contributed to several high-throughput sequencing projects at Imperial College London. So Dalia, the floor is yours.
Yeah, can you see the slides?
Yes, we can see your slides and we can hear you fine.
Thank you. So thank you very much for the introduction, and it is my pleasure to speak about the generation study and actually speak about some of the results that we already have, because over previous years we spoke a lot about what we are planning to do. So it's nice to change. So just a very sort of short introduction why we're doing it. And the whole sort of motivation for the study was that we estimate that there are around 9 children born each day in the UK with rare treatable genetic disease, where early intervention is crucial to improve their life outcomes. And we want to explore whether the sequencing whole genomes at birth could help us to find and identify those babies so that their life outcomes are improved. We do expect to find around 500 babies with these conditions expected around the study, but we keep adjusting that number as we go along, as we're getting results. However, this study is not just about utility and feasibility of a newborn screening, which we're doing in partnership with NHS. We also want to understand of how baby's genome can be used in discovery research, as well as benefits and risks and broad implications of lifetime genomes, which Harriet will talk a little bit later about. So everyone who is enrolled in the study consents for all these three arms of the study. So I'll speak a little bit about the result, but just before going to that, I wanted to share the slide, which I really like, which just comes from one of our colleagues, Amanda Pichini, which always compares genome newborn sequencing with wobble board. There are a lot of aspects which can be sort of beneficial or harmful or contentious in this area. And therefore, we're trying to, as the whole study, we're trying to address all of them to the extent that we can, which is how do we get consent, how do we balance the child's right to be identified and benefit from a best attainable healthcare versus individual sort of choice, how do we achieve equity in the genome screening, what results should be returning, how do we return them and communicate and support both clinicians and families, and do we have a workforce ready for this change, and how do we do it without disrupting existing standard of care or also already resource-trained services. So I will not have time to speak about all of that in my, I think, 10 minutes remaining, but if you have any questions, we're always sort of happy to talk about it more, and so just please contact us and ask questions. So this is high-level overview of a participant's journey in our study. So mothers learn about the study usually while they are pregnant, and we consent, we have time to think about it, discuss, explore benefits, or maybe whether it's the right study for them, and we consent during pregnancy before the baby is born. The vast majority of samples are being taken by birth. Our primary sample type is cord blood. However, there are opportunities to take other sample types from capillary blood after the birth if cord blood is not taken. Then we do whole genome sequencing with short read sequencing and data analysis. For the screening arm, we screen for a specific gene conditions pairs. We screen less than 500 genes, for which corresponds to around 200, over 200 conditions. And we've all been selected to be severe, high penetrant, where treatment needs to be initiated by the age of 5. And we have the treatment, importantly, is equitably accessible in the NHS. And you can find more information about how we chose those conditions and what conditions we saw on our website using this QR code. Then if nothing is identified during the screening, the participant gets either email or letter, depending on their choice, with no condition suspected result. However, if condition is suspected, the clinical care pathway within NHS is initiated. So we send a package with the result to a specialist clinician. There are over 200 clinicians which agreed to work with the study and return those results to participants. And we also don't send to clinicians just their genetic results, because that wouldn't be very helpful. We get like a whole package with available support as well, which informs about the urgency, about what confirmatory tests are suggested, what outline of management and support available for families. Because although clinicians are specialists for the conditions, we are usually not used to deal with families who are not expecting to have a baby who has a condition. They are so used to have a patients and talking with families which don't expect you to call and sort of saying that, oh, it's maybe something not quite right with your baby, is very different conversation from having a patient in a clinic. So we try sort of to support them. And eventually all the genomes and linked health data, which Joanna will talk a little bit more of what data sets we are going to link, will go into National Genomic Research Library. And obviously participants can withdraw from the study at any time. So we're currently operating in 47 recruiting hospitals all across England, and that number will increase even further by the end of the year. So you see it's big logistics. We have two sequencing centers. We work with two sequencing centers, one with Illumina in Cambridge, Kingston, and another with Revit in Manchester. So it's also various contingency, but also covering geography of England is a little bit easier. So as this was snapshot from 2 weeks ago, we had over 20,000 participants recruited. About 3/4 of them had sequence and genomes analyzed, and we had 50 condition suspected results. I looked up this morning, I think we had 54, 55 already, but it changes every day. We did quite a lot of work to refine our how do we prioritize and report the variants, because majority of the participants are expected to get no condition suspected results, so would want to reduce manual need for manual review for those variants. So we optimized this algorithm quite a lot and actually now published the paper, so I will not talk through the details, but in the sort of very short, we try to prioritize only variants which are highly likely to be pathogenic or likely pathogenic after manual review by clinical scientists. And we currently have these variants prioritized in around 4% of the genomes that process through our pipeline, and about 1 in 10 of them are deemed to be reportable cases after manual review. So what have we found so far? Less than a third of all results we've seen come from the conditions that already are being screened in UK blood spot screening. And that's not surprising, because obviously these are some of the most common treatable conditions. And there we already can compare with the result from the blood spot screening. And if you look just on the top of that, it seems a little bit mixed picture. For some conditions like cystic fibrosis, we have like perfect concordance. And with some of we have like these discordant results. And there it's a bit of a mixture, because for some of them, we still need to work out of what's going on. It may take time. So for example, for the OX2 gene, we have some discordant results. However, we know that congenital hypothyroidism associated with this particular gene is quite often evades traditional newborn screening. So we need a bit more time to see what phenotype the babies develop. And some of the discordant results are due to variants being in cis rather than in trans. Or one of the examples with PKU, which I won't go into too many details, but these were two variants which are both pathogenic, but actually when they are in combination, they turned out to be having a very, very mild effect on the level of phenylalanine in the blood. So after reviewing blood spot results, it was decided not to return this result back to the patient, or to participant, rather, it's not a patient. But more interestingly, we saw conditions which we report which are not in the current blood spot screening, because that's why we're doing the study. And these ones, as expected, fall into really large range of clinical specialties and really a lot of genes, although we see some conditions like hemophilia or osteogenesis imperfecta repeated in few times. The vast majority of them are different specialties, different genes, different conditions. Some of them extremely rare, like in ophthalmology, we have a condition with associated with RPE65 deficiency, which frequency is about 1 in a million. It takes a bit of time to get all the outcomes. We're still waiting of a lot of outcomes, but from the ones that we know about the outcomes, we had 15 confirmed positive and 1 confirmed negative, which was like kind of a variance being in cis. And about 2/3 of the confirmed positive were the cases which were not diagnosed and not known before the screening was returned, because in some cases, the condition is already known in a family or baby already presented with the symptoms. So it is very encouraging that we're finding right things, and that we even finding the most of the right things before at the time when it's helpful. And I'm running out of time, but I will 2 very quick stuff examples. One is hemophilia case where it's a little bit of a question whether we should return it because it was a variant associated with a mild phenotype. However, clinicians, consultants, hematologists strongly advise that it is useful for a baby with standard of care, or having that information in child's clinical notes in case of major injury or surgery or some stuff other procedures. And the result was returned and was confirmed. It turned out there was some family history, which family actually didn't really think much about it until they got this result, but it was clear true positive. Some of the conditions are a little bit more sort of tricky to know and challenging whether they are true positives or not. So, for example of this OTC deficiency, which is usually a condition which must manifest really early in life. However, this variant that we found is described in multiple families, but is described as late onset. However, very, very severe, because in majority of described families, it was fatal still quite early in life, although maybe not this early as like 5 years, which is defined by our loss of condition results. So again, this was decided to report back. And the baby was started on low protein diet, even despite confirmatory tests not showing anything. But this is the challenge with genomic screening, because we find conditions before we manifest. So we don't always can say that all confirmatory test negative. It actually means that a baby doesn't have a condition. And just sort of to finish off and pass on to Joanna, some of my final thoughts is about that it took us a long time to prepare the study, but actually all this feasibility modeling and all sort of the preparation really resulted in quite smooth rollout and us being able to find the results, return them, and families sort of having follow-on stuff care as expected. And we have a lot of challenges still ongoing, and we will need to evaluate results and seeing what the impact is. But hopefully that will long-term goals include exploring broader research opportunities that Harriet will talk about later. And I'll stop here. Observe acknowledgements. So just find how to stop sharing.
Thank you, Dalia. Fantastic talk, a great overview of the study and some of the opportunities and challenges, including that point about finding conditions before we feel they've actually manifested. So now we're going to move from that design and kind of genetics overview to exploring more of the evaluation framework. So it's a great pleasure to introduce Joanna Ziff. Joanna, if you want to start sharing your slides, please. Joanna is the evaluation and performance lead on the Generation study. She has 10 years experience working in healthcare policy and analysis, and this is at the Department of Health and Social Care, the Cabinet Office, and 10 Downing Street. And Joanna has a PhD in genomics. Joanna, the floor is yours.
Great, thank you so much. And thank you so much for inviting me here today to talk a bit about the evaluation of the generation study. So now that Dalia has given you a bit of an overview of the study, I'm going to go into a bit more depth on how we are generating the evidence that will hopefully provide the evidence base for future commissioning decisions. Okay. I think that's moved on. So when we started the generation study, it was really important to us to embed evaluation right from the onset. We've known from previous work that we've done in Genomics England that making sure that we capture evidence as we go through the study rather than doing it retrospectively is really key to generating a really strong, robust evidence base. So right from the get-go, we established an external working group. This included members of NHS England's Genomics Unit, the UK National Screening Committee, patients from our participant panel, and also academics with a range of different relevant expertise to our evaluation, including health economists, implementation scientists, behavioural scientists, and health informaticians. And together, that group enabled us to develop an evaluation framework. On recommendation from that group, we decided to outsource a large component of our study to an independent academic research group on the basis that we didn't want to be seen to be marking our own homework. We wanted that level of independence. And when we're going out to sort of interviewing participants, we want to make sure that they're being really honest with the results that they're given. And we felt that we would have a greater degree of that if we went out externally. So we went out to tender to identify an external research group who are conducting a kind of large proportion of our evaluation activities. However, there are certain components that we are choosing to still do in-house, and that includes things like surveys and some of our statistical analyses. Our evaluation framework takes a mixed methods approach. We are collaborating across a wide range of different research groups and also across the third sector. And through our evaluation, it's really important to us to firstly answer our research questions. So for those of you who might not be familiar with those, they are published in our protocol, which you can find on our website. It's really important that our evaluation helps us to facilitate evidence-based decision-making for discussions with future commissioners. And also, given that we are a taxpayer-funded study, we're funded through the Department of Health and Social Care to make sure that we are holding ourselves to account. So our evaluation framework consists of 4 key components. We have a process evaluation, a performance dashboard that enables sort of real-time monitoring, an impact evaluation, and a health economic model. So we have 5 primary research questions. I won't read these all in detail, but again, these are all available on our protocol, but they cover 5 key areas. So one is looking at whether whole genome sequencing in newborns is feasible and acceptable. And that's to a range of different stakeholders, our participants, their families, the public, healthcare professionals. We're also looking at uptake and results, and this we're kind of monitoring through our performance dashboard. So we're looking at whether uptake and results differs by region, by various demographic factors. And it's really important to us to monitor this in real time so that we can be really reactive and make changes to the programme to make improvements as we go through. We're also looking at cost effectiveness, as I'm sure you can imagine. We are developing a health economic model and doing various other cost effectiveness elements to our evaluation, which I'll touch on in the next slide. We're also doing an impact analysis, so looking at the impact, both positive and negative, of the programme on a range of stakeholders and the wider system. So that includes our patients and their families and the healthcare system more broadly. And finally, it's really important for us to consider experiences and attitudes of all of our stakeholders to whole genome sequencing in newborns. And we know that there's a real wide variety of opinions there. So we want to make sure that we're capturing that across the piece. So I mentioned our external evaluation partner. I think some of these people are on the call today, which is brilliant. It's a really large team. This isn't everyone. There wasn't space on my slide for everyone, but it is headed up by a team at UCL, but it also includes researchers from a range of other research institutions, including the Institute for Child Health at Gosh, Queen Mary University London, Warwick University, and also 2 third sector organisations, Genetic Alliance UK and Breaking Down Barriers. So our external evaluation, which is the kind of largest component, consists of 7 studies. Again, this is all available on our website in far more detail than I've got on this slide, but I'll just touch on the kind of key areas that we're focusing on through this external evaluation. So study 1 looks at goals, challenges, and early lessons in implementation. So this is a study that has interviewed a range of PIs and recruiting midwives at our earliest sites to come on board to understand what have been the major challenges to getting up and running with the study, and what have been the key facilitators and what their opinions and experiences have been. Study 2 is looking at the experiences and attitudes of parents through surveys and structured interviews. This is an ongoing piece of work that will stretch throughout the study, and a sample frame is being conducted by the external evaluators to make sure that we are representing groups from ethnic minorities, and also making sure that we have enough findings from those who have received a condition suspected result. Study 3 looks at wider professional viewpoints. So that is a survey with healthcare professionals to understand their experiences and attitudes. That includes both healthcare professionals that have been directly involved in the study, both at the recruiting end and also at the returning results end, but also more broadly, healthcare professionals who perhaps aren't directly involved in the study, but whose opinions we want to capture on it. Study 4 is a study that is now completed. This is looking at the views of the rare disease community. It was a survey that was conducted by our collaborators at Genetic Alliance UK to understand the opinions of different patient support groups. Study 5 is yet to begin, but we'll kick off shortly. This is a public views survey, which will be conducted through a collaboration with a market research company. And then study 6 is some of our work on cost effectiveness, which is being conducted by our collaborators at Queen Mary. And they are looking at healthcare resource use and costs, quality of life outcomes, and non-health related outcomes. And lots of the data that they're gathering through that work will help populate our health economic model. And finally, study 7 is looking at clinical utility assessment. So looking at how the outcomes of participants in the generation study differ to patients who have been diagnosed with comparable conditions, but are not part of the generation study, using a longitudinal database called eChild. So when conducting our evaluation, we've come across a number of hurdles and blockers. Namely, it's really difficult to fill in certain evidence gaps. And this isn't unique to the generation study. Lots of these gaps are relevant to all screening programs, including the newborn blood spot. So we've been trying as best as we can to collaborate to try and fill some of these gaps, but we know that some of them will remain even at the end of the study. So our kind of 3 biggest challenges really is firstly, the production of comparator data. Because of the study methodology, we don't have an inbuilt comparator cohort. So we're trying to identify appropriate comparators through a range of other sources. And that includes some of the data sources we hold in Genomics England through our other cohorts, for example, 100,000 Genomes Project and GMS participants. We're also looking at some longitudinal data sets. I mentioned eChild on our previous slide. We can also look at disease registries, and we're also in active discussions around collaborations with birth cohorts as well to see if we can fill some of those gaps. There's also a bit of a gap around evidence on natural history. Because some of these conditions are just so rare, this evidence is generally lacking worldwide. So obviously we're looking at kind of the usual routes, published literature, disease registries, but you may be aware there are some other research studies very similar to the generation study being conducted internationally. And so we're seeing if any of those collaborations can help us fill some of these gaps. And finally, looking at long-term data capture and identifying false negatives. So this is to do with our ability to follow up with our participants over the medium to long term, making sure that we understand what the outcomes were for both our screen positive and screen negative participants. This is a really challenging area, but we are trying our best to do so through building up our engagement with treating clinicians and participants. And we are also doing a sort of separate project, which is looking at a deep dive into a subset of our participants, which is called Babies in Focus. Finally, my last slide before I pass on to Harriet. This isn't necessarily evaluation, but I know that this will be of interest to many of you, which is looking at the secondary data sets that we're linking to within the NGRL for the generation study. So far, we've prioritised data sets for secondary linkage that have value for evaluation purposes. But given that we were linking to them for evaluators, there's also additional benefit for them potentially for discovery research. So these include hospital episode statistics. We've already got linkage to this one. This is at the moment in a ring-fenced area that's only accessible to our evaluators, but we will make that in the public area later. We currently already have critical care, outpatients and admitted patient care, and are looking to onboard A&E and ONS linked mortality data early next year. A new data set for us in GEL is the maternity services data set. We expect that by the end of the year, and that will provide maternity data, antenatal data on all generation study mothers. And another new one that we're collaborating with Imperial on is the National Neonatal Research Database. We expect to receive this data pretty imminently. We were assured it would be in September, and I know we're right at the end of September, so I think it's going to happen pretty soon, I hope. And this is data for babies who have been admitted to neonatal care. So any babies that have been to the NICU or the special care baby unit who have data, we will be able to obtain and link that data eventually to their genomic data. We're open to discussions about additional data sets that we might not need for evaluation, but might be of benefit for further discovery research. So these are just some of the things that we've been talking to various of you about. The community services data set, we actually have that available already, but there are some data quality issues at the moment that we're working through on that one. We know some of you think that the paediatric critical care minimum data set would be of value. Others have mentioned the newborn hearing screening program data. And we're also looking at the option of primary care data, which we're already exploring for some of our other cohorts here at Genomics England. So just to finish off, I have included some links here to some kind of relevant evaluation information on our website, but I would recommend going to our evaluation webpage, which includes all of these links if you have more if you want more detail on any of this, because I appreciate I've had to go through this really quickly. And also, if you want to talk to me, and especially if you want to talk about data and linked data sets, then please feel free to drop me an email. Thank you very much.
Thank you, Joanna. Thanks for providing that overview of how you are sampling attitudes, coming up with data for cost effectiveness, for understanding outcomes, really generating that framework for evidence-based decision making. A reminder to our audience, please feel free to put questions into the Q&A and our panelists will answer them on the fly if they can. Otherwise, we will discuss them as a group after our next presentation. And our next presentation is going to focus on ethics. We're going to move from the evaluation framework to ethical considerations. It is by Harriet Etheredge. She is the ethics lead for newborns at Genomics England. She's a medical bioethicist and health communications specialist. She's based in the UK. She began her career as a transplant ethicist in South Africa and experienced firsthand the significant complexity of providing tertiary medical services in context with substantial resource constraints. Harriet has been involved in some world-first studies, particularly in liver transplantation and HIV, and she's done substantial transplant policy and advocacy work, foregrounding patient-centeredness and transparency as core ethical values. So over to you, Harriet.
Thank you very much. Good afternoon, everyone, and thank you all so much for being here this afternoon. So I'm going to take you on a whirlwind tour of the lifetime genome, and I will caveat this presentation by saying it really is a whirlwind. And I'd be very happy to answer questions about it after, or you can always get in touch with me, the details at the end of this presentation. So you'll recall from Dalia's slide the third aim of the generation study, which is to explore potential risks, benefits, and broader implications of storing a baby's genome over their lifetime. And just to emphasize here that what we're doing is exploring this idea. And this is our first attempt to start answering this research question. So this is really early days work for us at Genomics England. I think before I tell you about what we did in 2024, I might try to set the scene, which is, what is the lifetime genome? What are we talking about? And there is no real clarity on a definition. So if you do a Google of the lifetime genome, you'll see a lot of results from Genomics England. If you Google something like reanalysis of the genome over the life course, a slightly more academic definition, a few other articles and resources come up. But really, there are several different ways of looking at this, and this was one of the areas we tried to unpack in our early work. So it may be something like in the top row of this slide, that at various transition points in a person's life, they would provide a sample and have a genomic analysis done, which might help with newborn screening, for instance, like the generation study, potentially in early childhood, at points where people are undertaking reproductive planning, or maybe in older age when polypharmacy and the risks of adverse reactions to drugs start becoming more acute. Or a lifetime genome might be, in a more pure sense, I think, the idea that a person has a genome taken at birth. This follows them throughout their life and is reanalyzed as a primary data point periodically, with other data augmenting it as we go through these transition phases. So we're talking about something in the realms of these slides here. So in 2024, we undertook a public standing group to try and start us off on this lifetime genome work. And I'm now going to share with you a 6-minute video, which is a summary of this group. And I hope it will just serve to bring it to life for you much better than I can by just talking you through it. So I'm going to start playing this now and sincerely hoping everybody's going to be able to hear it.
We've been given opportunity to kind of explore our various different thoughts.
So you go in with an open mind and you learn something new.
It allows you to give your true feelings about a subject.
I feel very much part of it, very, very proud actually to have been part of it.
Genomics England is currently undertaking the Generation Study, which is a research study that aims to recruit 100,000 newborn babies, and we sequence the genomes of those babies. Part of the study involves storing the babies' genomes for future research into genes and health. One of our main research objectives is to understand the risks, benefits, and potential uses of reanalyzing that genomic data over a person's lifetime.
If genomics is going to make the difference we believe it could have in the future as part of the fabric of everyday healthcare, the work of this group and the work we do like this, that is an important part of shaping it as the science and the health economics and so on. And that needs to be something that we really understand the diversity of views on. That's really critical, and it's really exciting to have groups that help us do that.
Hopkins Van Mill were involved in recruiting and delivering the actual group sessions.
And then pick a role.
Hopkins Van Mill is a social research agency. We specialise in bringing together people over a period of time to discuss, explore different topics that are of interest.
Yeah.
There isn't a script that we follow. We follow where the conversations take us within the remit of the objectives that Genomics England have.
You hear from a variety of people and you learn about everything.
This was deliberately set up as a panel that would meet on 5 occasions during the year, and thinking about a lifetime genome resource, how it can be used in a person's life for their own health benefits. So that might be screening for health conditions, it might be helping to use your genetics to say which medicines you will respond to better than others. So a wide range of different uses for your health. All of the participants had past history with Genomics England. Some of them, it stemmed back to 2021 when they were involved in the first public dialogue on whole genome sequencing for newborn screening.
From then I was lucky enough to be invited back for I think it was the first face-to-face sessions.
We had run in that instance another Genomics England Hopkins Van Mill public dialogue on research access. We were bringing together these 2 cohorts. We hadn't all met before, but they had never met each other before.
People ultimately had an environment where they felt safe and could speak their minds and be transparent and challenge each other, and most importantly, challenge us at Genomics England.
The mix of people that have been picked for these workshops, I think, has contributed towards my enjoyment a lot. There were genuinely so many different perspectives and cultural backgrounds included, that everyone really had their own nuance to how they basically saw every single perspective and all the key topics and kind of how they were discussing them. I love that. I love when people challenge my perspective. I love when people feel comfortable enough for me to challenge their perspective. But in a safe environment, there's no no one getting personally offended or anything.
I mean, I'm sort of sometimes like a skeptic. So mostly, my point of view was quite contrary to everyone else. There was no pressure to sort of comply to one point of view or the other. If you have a different point of view, then you just go with it.
I suppose from there, your own thoughts just spiral into new views and opinions, and it just brings about all different kinds of conversations.
Because at first I was a little bit, okay, this person's got a really strong opinion, this person's got a really strong view. But when you learn about them, and because I'm now more considerate and thoughtful to why somebody might be acting a certain way or reacting to a certain situation differently. It's actually also made me grow a little bit as a person as well that way.
Areas that we've covered have been very, very fundamental. I've particularly enjoyed discussing about consent, disclosure, which we kind of covered today. This is that sense of worry that a parent naturally, especially as a mother, naturally has.
It's funny, every session's gone off in a different direction. We've literally right until the last minute been talking about things that we've never previously considered.
I think there's some immediate things that has sort of helped us crystallise what we know we need to focus on. And I think then more broadly, it helps us think that if we are successful in a generation study and perhaps want to go a step further with our parents and babies, starting to think about some of the things we're going to have to think very carefully about as part of that steps. And I think for me, this is very much the start of a conversation, and I truly believe and want to make sure this is a continued conversation that we keep having.
The whole experience of being able to participate in something as fascinating as this has been a once-in-a-lifetime opportunity as far as I'm concerned.
I feel like all of my kind of big concerns from the start have basically been answered.
Really interesting, really happy and privileged really to be a part of it.
You know that if your trains are delayed or you're having trouble getting down, you actually really want to be there because you know your voice is important in the group and your opinions and life experience is also important.
So I'm due to give birth next week. The last email we received, I said, okay, if I haven't gone into labour, I'll definitely be here.
You can see it's a company that really cares about, and value your opinion. It's just refreshing to see that you can still trust people to kind of like, with your opinion, you can still trust them.
So I hope you enjoyed that snapshot and it gives you a sense of what we did, but how did we make this mean something that we can take forward into some next steps? So I'm going to go through these final slides quite briefly, but hopefully give you a sense of what we've been doing in terms of analysis here. So consent was invited and obtained from all of the participants in these groups, and we audio recorded the sessions, transcribed them and did some thematical analysis, primarily using in vivo. We triangulated our main themes across multiple data sources, and we have a multidisciplinary analysis group that has really helped us to sense check this. We also have some quantitative elements that we brought in as part of this group, like Likert scale type questions that we used across the meetings to gauge changes in perceptions. And I will share the results of those with you at the end. We really discussed 4 key applications where a lifetime genome might be relevant. And in terms of these, pharmacogenomic applications were the ones that really resonated strongly with the participants in these groups. And people were saying, this is a no-brainer. Why aren't we doing this already? So really strong support for pharmacogenomics. Mid-childhood screening was also something that the group felt strongly about. Polygenic risk scoring, there was maybe a bit more doubt there, and carrier testing opened up some really tricky conversations in the group. So of course, there are a number of confounders here, but carrier testing was one where we felt we'd really need to do a lot more work to understand where some of the reservations were coming from there. And then the key themes as a result of our analysis are on this slide, and I'm not going to discuss them in any detail other than to say that the first theme, the impact on family dynamics, was a really overriding finding from this work. And the participants in our group were really concerned about how us providing genetic information could impact not only the person, but the family as a whole, and issues about disclosure and consent in that context were things that we'll really have to look at very carefully in future. Over time, from some of our quantitative data, although of course this is a very small sample size, the perceived benefits of this lifetime genome resource started high and increased over the time that we did these groups. The perceived risks started moderately high, decreased slightly over time. And we asked our participants, would you have a lifetime genome? And we did get the majority saying yes, but it was by no means unanimous. So not everybody was convinced. In conclusion, I think we can say that lifetime genome work, as we presented it here, has clear potential, but also clear risk. Pharmacogenomics is the most compelling potential use to this group in particular, followed by childhood screening. And of course, we need a lot more research here, especially in terms of family dynamics, to say that there are some limitations of our approach, especially small sample sizes. And I can speak about those in more detail as well. And for us at Genomics England, what are we doing with this information? The big picture is that we're feeding insights from this group into our long-term strategy, especially looking at how genomics could play a critical part in clinical health interactions for 50% of people over the next 10 years, and also feeding insights from this into our future spending review initiatives, as well as the next steps of the generation study. And to those of you who want to hear more, we have a podcast on this particular subject if you're interested. And if you have questions, my email address is on the slide, and please feel free to get in touch. We'd love to hear from you. Thank you very much.
Thank you, Harriet. That was brilliant, really hearing about deep and meaningful engagement with the public around the idea of a lifetime genome and all the opportunities and challenges that have emerged from that. So we have about 15 minutes now for the Q&A session. I encourage the audience to please do submit questions. I can see there's a number there already, but whether you feel you're an expert geneticist or a policy or just a member of the public, please feel free to put questions in. There's a great chance for discussion now. So just going through the ones that are here, there's a question. It looks like this is probably for you, Dalia. So Emma Rath mentions that there are about 89,000 genomes in the Genomics England research environment. So are there plans for these additional 20,000 plus birth cohort genomes or screening genomes to be added to that research environment? If you could comment on that.
Yeah, absolutely. So as I mentioned, everyone who enrolls in the study, it's just one type of consent. We consent for screening arm, but also for the research arm, and their genomes together with the linked data, so the similar data types that you already have for genomic medicine service or 100,000 genomes patients, like have hospital episode statistics, but also with other linked data sets that Joanna mentioned, like maternity services and neonatal records, some sort of will be linked there. Obviously, assuming participants don't withdraw, we have very small number of withdrawals, but yes, all of that will be in research environment. We don't have a timelines, if you want to ask that. We haven't quite prioritized it at the first of the study because we really prioritize study up and running. And the value of this resource will come with time, especially when the children grow and stuff more of this clinical data comes available. But yeah, it will be there.
Thank you, Dalia. There's a lot of comments about, congratulating the team on a fantastic study. So one individual was wondering how you're going to handle the reanalysis of the data should new genetic evidence for your target conditions come to light. And of course, is a very important issue that would also apply to diagnostics for people with rare disease, not necessarily screening, but in later life as well. So Dalia, that's probably one for you as well.
Sure. So there are simple question for screening arm, we are not going to do reanalysis. And that decision was made before we started the study. We had a lot of engagement and public dialogue, and we actually asked families and stakeholders what we think about it. Should we be reanalyzing it regularly and updating families of the results? And it actually was quite unanimous no, because families felt strongly we don't want to have that kind of threat hanging above them that we get in negative results, but then something sort of like any day they can be called again and saying, well, actually we found something else. Because now here it's a different context from patients with rare disease. These are families with majority of babies don't have any conditions. And so in that context, we decided not to do the analysis on a regular basis. However, as part of this Lifetime Genomes project, we will be looking at what would have happened if we did this reanalysis. So, for example, because we'll have the clinical data from the participants. We will have their genomes, and we may sort of have some research ongoing, sort of explore of what would be if we were doing this reanalysis of what we might or might not find, and but most of on a research basis.
So Dalia, if I'm following your answer there, so there would be no reanalysis, you're saying, or no return of results, and that would extend also to if a research team works with the data and they feel they've found a pathogenic variant, that result similarly would not automatically be fed back. Is that a correct interpretation?
It is. We do have in the consent some exceptional circumstances that if something is found in the research, which there is a very strong evidence that it may benefit the child, whereas family can be recontacted. So it's not completely no, but we haven't quite worked out of what mechanism would be and what would be the thresholds of that recontact. So it's not sort of automatic feeding back, but the door is not completely closed, because if there is something found, which there's very, very strong evidence of that, it's of big benefit of family to know that we might be able to recontact. And also families can be recontacted to participate in new studies. So we have a consent to recontact. So we may sort of design a study saying like, well, do you want your genomes to be reanalyzed? And then consent proportion of families for that particular study or something like that.
Thanks, Dalia. And on that topic of consent, this is one for you, Harriet. Will babies be reconsented? So Dalia mentioned consent to recontact. So will babies be reconsented as they grow older? And what happens to results for late onset disorders that are not expected to require treatment in the first 5 years? Are they returned later? So Harriet.
So we will be approaching all of the when they are 16, so no longer babies or children in the generation study at the time that they turn 16, to invite independent consent as adults to continue participation. And for anybody who we can't get hold of, we've got a system in place to make sure that they are appropriately withdrawn over an appropriate period of time. As to returning conditions that might onset later, as far as I know, we don't have any of those in the generation study, but Dalia would be better placed to answer that part of the question. So I'll hand over to Dalia for that.
Yeah, you're correct. So one of the principles was of condition to be included is that the care intervention needs to start within the first 5 years of life of the baby.
Thank you. And then Joanna, there's one for you here from a neonatal doctor wondering whether you could expand on how linking the generation study genomic data and the NNRD will be utilized. So what are the potential applications there?
Sure. So we originally agreed with Imperial that we would link to the NNRD database for our evaluation purposes. So our health economists are calculating healthcare resource use costs. So understanding about the healthcare interactions in that neonatal period, that's data that doesn't appear in HES to a large extent, will be really beneficial for them to do some of that health economic analysis. And similarly, some of the clinical utility analysis as well, to understand how many healthcare interactions are had by some of the participants in our study in that neonatal period. So that was the original vision when we decided to link to that data set. However, we anticipate it will have far wider benefits for discovery research purposes. So the data dictionary for the NNRD is available on the Imperial website. It's a substantial data set. It's got lots of different fields, and there's all kinds of things that researchers could use here, looking at things like genetics of preterm birth, looking at various different neonatal outcomes and neonatal interventions that might be of use. So there's a wide range of different potential applications here, depending on different researchers' research interests.
Thanks, Joanna. Harriet, another one for you. Could you explain what the benefit of resequencing someone's genome at key life points instead of just looking at the initial sequence again?
I mean, briefly, I think there are many potential reasons you might want to resequence. The sequencing technology is changing, and who knows, in a few decades, we may have much better sequencing technology than we have now. So that's one of the options. The other thing we're looking at here as a challenge is the storage of this genomic data. If this was something we were going to roll out across the country, for argument's sake, storing the genomic data of all of those people, these are massive files, could potentially be a real infrastructural challenge. So it's those sorts of balances. So resequencing over periods of time, especially as sequencing also becomes much cheaper, may be a more effective way of delivering a sort of really world-class service if we were going down that route.
Thanks, Harriet. And of course, the sequencing technology and capacity could change, right? There's long read, T2T sequencing, lots of new opportunities could emerge along the way. These are great questions, folks. Please keep them coming in. Dalia, one from you for you again here. Do you anticipate that the generation study will enable better definition of phenotype from milder conditions? Right. And I think some of your results hinted at that already, you know, where you might have a particular genotype that's causal, but not necessarily for the most severe or a more severe form of the condition.
Yeah, I mean, I think what we realized when sort of trying to define of what is another question which I answered in a chat about what is positive, what is negative, what is suspected positive is but for a lot of these rare conditions, there are no really good case definitions and all like lifetime sort of understanding of the natural history of the condition and how it changes if you intervene earlier or later. And also with phenotype-genotype correlations also not always straightforward. So yes, we anticipate a lot of learning about the definition of phenotypes, about the penetrance, about the sort of these conditions, and that's one of the also aims of having always genomes in the research and the links clinical data, so that's not one time off result, but it can be followed up.
Thanks, Dalia. And another couple of questions here for you. And this is what I had myself, actually. How long does it take to provide feedback to the participants? And I'm curious to know how that relates to feedback from a more traditional heel prick type test. So that's the first part of the question. How long does it take? And the second one is, are structural variants also included in the analysis?
Yeah, I read this question and I realized, but for some reason I lost one of the slides, which should have had in my presentation with answering that question about the turnaround times. And also of sort of what samples we have and a bit of ethnicities of the ancestors of the patients or participants. But turnaround times currently are around 3 weeks. Both for conditions suspected and no conditions suspected. Obviously, when we just started, we were a little bit longer, as it was, and we're still working out towards kind of our 2 weeks target, which would then place it in line with traditional newborn screening. So we're not too far. We do get some babies past even 3 weeks, obviously some a bit longer, but you know, we want to be able to do it consistently. And structural variants inclusion analysis. We currently run the same pipeline, if people are familiar with what we run in the genomic medicine service, which currently includes copy number variants above 2 kilobases. We very soon will introduce calling copy number variants, deletions and tandem duplications across the whole range, so from like 50 base pairs towards upstream range. With other structural variants, it is quite complex, and we know that some of them, for example, hemophilia, like most common inversion, is just not possible to find it from short read, so there are some limitations there from the technology that we use.
Okay, thank you, folks. Listen, we're coming up to the hour, so I just want to take the opportunity to thank our speakers, Dalia Kasperaviciute, Joanna Ziff, and Harriet Etheredge. I've certainly found it really, really insightful, learned a lot about the generation study and all the opportunities from it. I would like to thank the community co-leads, Sanjay Sisodia and Elijah Baer, and also the communities and communications team at Genomics England, Eleanor Rochier, Zan Sieghart, and Keris Ballard. So I hope everyone has a great afternoon, and please do consider joining us for our next seminar. Good afternoon.